I think there's a bit of a loop going on somewhere. There's an echo, at least on my computer.
Chalo, let's start now. Welcome to the 86th edition of Thursday Musings. Next slide, please. So, Dr. Tofan Pati sir is joining us in a moment. So, we'll start now. Dr. Tofan Pati is the chairman of the program. Next slide. Moderated by Amrit. Next slide. And myself, Aleem. Next slide, please. So, let me welcome Dr. Y.C. Janardhan Reddy sir. Everyone knows him, but still we have to honor our chairperson. He is Professor of Psychiatry and Head of OCD Clinic at NIMHANS, Bangalore. He is a visiting Commonwealth Research Fellow at Oxford University Department of Psychiatry from August 1999 to February 2000. Nearly 200 publications in various journals, various presentations. He has been a chief investigator of many studies on OCD and bipolar disorder. He has received research grants from ICMR, Department of Science and Technology, Department of Biotechnology of the Government of India, Canadian Institutes of Research, and recently from NIMH, USA. He is a member of WHO Working Group on OCD and related disorders for revision of ICD-10. He is a lead author of IPS Clinical Practice Guidelines on OCD and Guidelines on CBT for anxiety and OCRDs. He has also been awarded prestigious Sir C.V. Raman State Award for the Young Scientist for 2011 by Government of Karnataka. Welcome, sir. Welcome to the show. Next slide, please. Let me welcome Professor Dr. Shubh Mohan Singh. He is a professor of psychiatry at PGI MER Chandigarh. Did his graduation from Patiala Government Medical College, MD in psychiatry from PGI MER Chandigarh. He is faculty in the Department of Psychiatry at Chandigarh since 2011. He is member of IPS, ISP, IPHA, IAGMH, and PDAI. He has won Bhagwat Award of IPS 2006, Murugappan Award IPS 2022, more than 100 national and international publications, 20 book chapters, 2 books. Research interest and area of work is community psychiatry, non-invasive brain stimulation, general adult psychiatry, and psychodermatology. So we have a very heavy panel. Sir, over to the chairpersons for conducting the session. The stage is all yours, Dr. Reddy sir and Dr. Shubh Mohan sir.
Yeah, is Dr. Reddy there?
Yeah, Janardhan sir is there.
Yes, we were just talking. Next slide.
So should I start or should I wait for Dr. Janardhan? Please unmute me.
Please make Dr. Janardhan his co-host. Sir, you can unmute.
Okay. Thank you, Aleem and Amrut, for the generous introduction. We have Dr. Singh also as a co-chairperson. We have today a topic on deep brain stimulation in obsessive-compulsive disorder, perhaps a slightly different kind of a talk than the talks that we have had on Thursday Musings webinars. Surgery in OCD has had a long history. It started off with lobotomies and leucotomies and became vastly unpopular. And many guidelines, including NICE guidelines, warned against employing surgical approaches. But then over the years, considerable amount of research has accumulated on the efficacy of both deep brain stimulation and ablative surgeries. Deep brain stimulation became popular basically because of the precision with which you can place electrodes and also reversibility of the whole process in the sense that you can switch off any time. And considerable research data has accumulated over the years on the efficacy of deep brain stimulation in OCD. Having said that, concerns remain about how effective it is, how long does it take for DBS to work, what kind of patients respond well to deep brain stimulation, what are long-term side effects, and so on and so forth. Now, it is in that context that this particular talk on deep brain stimulation in OCD achieves importance, because we know that about 10% or 15% of the OCD patients are so severely ill that we have done everything that we know of, including non-invasive brain stimulation, a whole lot of psychotherapies and pharmacological augmentation strategies, but still patients don't show adequate improvement. So we have a treatment to offer. Dr. Shyam Sundar Armugam, he is my colleague, professor of psychiatry, the Department of Psychiatry, also my colleague consultant in the OCD clinic. He has recently been awarded the DBT Wellcome Trust Intermediate Fellow for deep brain stimulation in subthalamic nucleus of OCD. So it is in that context that Shyam Sundar is the most suitable person to talk on DBS. Is quite well read on the topic, and I'm sure he will present the state-of-the-art literature on the role of DBS in OCD. Shyam. Dr. Singh, do you want to say something before we?
I think you really introduced him very well. I think it's
You can introduce
a very interesting topic. Yeah, I think it's an interesting topic. I think we can discuss after the talk. So I would request Dr. Shyam Sundar to make his presentation.
Thank you, sir. Thank you, everyone, for the generous introduction. So I'll just try to share my screen. I'm sorry, there has been a small technical issue. I'll just join back. There is some issue with joining the screen. I'll just join back. Just 2 minutes.
please unmute Dr. Shyam Sundar. Yeah. Please make him co-host. He has joined again. Sir, you can go ahead now.
Yes, sir. Thank you. Thank you. I'm extremely sorry for the confusion. Actually, I had to quit it to share the screen. So there was some issue with the app. So, okay. Thank you, everyone, for the introduction, and I'm apologies for the delay. So I'll be discussing about deep brain stimulation for OCD. So I'll just directly go into the topic. Yeah, conflict of interest, like what Dr. Janardhan Reddy said, I'm funded by the DBT Wellcome Trust Alliance for a study on DBS. Yeah, apart from that, I don't have any other conflicts to discuss. So like what Dr. Janardhan Reddy had discussed, surgery for psychiatric disorders had a checkered past. Modern surgery, we can say, is from the time of Egas Moniz and Walter Freeman, and for people who started doing surgery for psychiatric disorders from 1930s and 1940s, where things like leucotomy and lobotomy were done. These involved sort of ablation of particular parts of the frontal cortices and its connection. But the surgery was not quite accurate, and there was also not clear-cut patient selection. It was a bit indiscriminately done, because of which there was a lot of disrepute for the whole concept of psychosurgery or surgery for psychiatric disorders. But in 1960s, especially in Europe, Spiegel and other people, Telerak and other people developed new techniques for more accurate positioning of the lesions or for various psychiatric and neurological conditions. This was known as stereotactic surgery, using special equipment and also using imaging. And during that time, cingulotomy and capsulotomy especially became quite famous. And it was found that people with OCD and depression preferentially respond to these procedures. This progressed, and then in 1919, which I'll be discussing a little later, people found that instead of lesioning, we can stimulate particular part of the brain with the help of certain electrodes, which from where deep brain stimulation started. And now this field has progressed over the past 2 decades so well that now people are trying to find the particular neurocircuitry circuitry or the white matter tracts which are abnormal in a particular disorder, and they're trying to target those with deep brain stimulation. So what is deep brain stimulation? Deep brain stimulation is nothing but stimulation of deeper brain structures through electrodes implanted in the brain. These electrodes are then connected to a battery, and this battery is usually placed below the skin, usually in the chest. And the advantage, as discussed earlier, was that the stimulation is flexible. There are a lot of electrical parameters that can be optimized so that you can have a balance between efficacy and side effects. And similarly, this is the electrode. You see, there are 4 tips that are seen in the electrode. So any of the tips can be kept on and other tips can be kept off. So there is some sort of flexibility of stimulation. If you feel that if one contact is stimulated, there are side effects, you can switch it off. You can switch another contact on. So this sort of flexibility is there with deep brain stimulation. So how does deep brain stimulation work? When people started deep brain stimulation, they primarily thought that it like giving very high frequency stimulation leads to a sort of depolarization blockade, or it causes some sort of functional lesion, in the sense that without causing ablation, it decreases the activity of particular brain regions. That was the theory in which it was started. And that is why instead of ablative surgeries, deep brain stimulation was tried. But later research found that it leads to various other changes, like it leads to changes in neurotransmitter activity, and it leads to widespread connectivity and activity changes in various other brain regions, which are connected to the targeted brain region. So currently people feel that like the most accepted theory or the mechanism by which DBS works is disruption of dysfunctional oscillations. That is, there are normal oscillatory activity that are seen in brain circuits. Usually the circuits connecting the cortical regions and the subcortical regions. This is normally seen, and during particular, say, cognitive or motor activity, the oscillations in particular brain regions increase or decrease. So this oscillation seemed to be dysfunctional in various psychiatric and neurological conditions. And so deep brain stimulation sort of normalizes this abnormal brain rhythm. This has especially been supported by the evidence that when deep brain stimulation is provided, the axons in the neuron are more susceptible to neuromodulation as compared to the cell bodies. This is important because we are actually targeting the white matter pathways rather than the gray matter, which contains the cell bodies. So I'll be discussing about these things in subsequent slides. So how did modern DBS originate? Prior to 1980s, many people had tried to stimulate deeper brain regions, but they were not able to provide continuous stimulation as a form of treatment. So intermittent stimulation was provided. But in 1980s, a lot of advances happened. Advent of microprocessors and various other imaging techniques. After that, people found that you can have a battery through which you can stimulate particular brain regions. So there is no need for the person to be connected to an external device. So this device can be implanted in the person himself or herself. So that's when people started studying, especially in the late 1980s, started studying DBS for various movement disorders. And slowly that replaced all ablative procedures. And now for various movement disorders, especially for Parkinson's disease, DBS is the most commonly used surgical technique. And even for other movement disorders like essential tremors, dystonia, DBS is preferred, and thalamotomy or pylotomy are ablative procedures are seldom performed. And these, for movement disorders, the pathology is considered to be in the basal ganglia. That's why basal ganglia regions are considered to be the are the most commonly used targets for movement disorders. In psychiatric disorders, the first report of DBS was for OCD. As I said earlier, capsulotomy, where the lesions used to be produced in the anterior limb of internal capsule, was the most commonly used surgical procedure for OCD, the treatment of resistant OCD. So a group of Belgian scientists, Newton and colleagues, they did their first DBS over anterior limb of internal capsule on the same area where the lesion used to be produced. And they found that it was found to be helpful. And after that, various similar procedures have been tried in various other psychiatric disorders, and evidence have been gathered over time. And various other targets have also been been attempted. Among these, OCD, major depressive disorder, and Tourette syndrome are the common indications for DBS in psychiatric disorders. Although there is some evidence for other disorders like substance use disorders, anorexia nervosa, and there is one recent study on schizophrenia too. So I'll be focusing more on OCD in this presentation. So what are the advantages and disadvantages of DBS compared to ablative surgery? The thing, like we discussed, it's a reversible neuromodulation. So there's no long-term side effects or less long-term side effects. Side effects might be reversible. The stimulator can be adjusted after surgery so that the efficacy can be increased. And the advantage is that sham stimulations are possible. So because of which we can do blinded control trials also to see, to control for placebo effect. Yeah, but the disadvantage is that it is more expensive, and since it involves a battery, the battery may have to be replaced periodically, and it usually requires a highly skilled interdisciplinary team and frequent monitoring for adjusting the stimulation. And its craniotomy is required because it's an open surgery. So these are the pros and cons of DBS. So DBS, a brief this thing about the opportunities and challenges with the DBS studies in psychiatry. So as I said, sham stimulation is possible. So randomized control trial is possible. And the advantage is the person can be his or her own control, in the sense that you can keep the stimulation on for 3 months and off for 3 months and see which period is more helpful for the person in a blinded manner. So that is a great advantage with DBS. But the challenges for DBS studies in psychiatry is that there is generally a latency of response. It has been seen that not only in DBS, even for ablative surgeries, there is a latency of treatment response. There is at least anywhere between 3 to 12 months of latency of treatment response. It's slightly lesser for DBS compared to ablative surgeries, but still there is a latency. Compared to something like movement disorder, especially in Parkinson's disease, the effect happens immediately. But in psychiatric disorders, we have this issue. And there may be a carryover effect where if you turn the stimulation on and off, in the sense that first you turn the stimulation on, then if you switch it off, the effect of the on stimulation might last for a longer period. So there's a need for a washout period in between for 1 or 2 months for the effect to go away. So this all these things complicate to randomized control studies for DBS in psychiatry. So DBS for OCD. So why do surgical interventions required for in OCD? As we all know, SSRIs and CBT are effective, but they are not effective in all patients. Around 50% of patients only respond to either of the treatments. And even augmentation strategies like antipsychotics are helpful only in around 30% of patients. So around 10 to 20% of patients are refractory to standard pharmacotherapy and psychotherapy. So these are the patients for whom invasive treatments or surgical techniques have been recommended, especially in those with severe chronic and disabling and treatment refractory illnesses. This is the selection criteria for surgical interventions that have been recommended by the Indian Psychiatric Society Clinical Practice Guidelines. So as I said, people with severe OCD, which causes substantial impairment in functioning and who are refractory to standard treatments in the form of at least 2 SSRIs, 1 clomipramine trial, 2 augmentation trial, and at least an adequate trial of CBT. All of these things, only if all of these things fail, we consider a patient for surgical treatment. And obviously the patient has to give informed consent, and other aspects. Contraindications, there are no absolute contraindications. These are relative contraindications because of the nature of surgery and consent process. Earlier, intellectual disability, psychosis, bipolar disorders, and even severe personality disorders were considered to be contraindication. But there is some recent evidence, especially in people with bipolar disorder and psychosis, showing that DBS and other ablative procedures might be helpful in this population too. So, yeah, these are the standard neurosurgical approaches for OCD. One is ablative procedures, where you create a lesion in a particular part of the brain. There are various ways you can create lesions: thermocoagulation, radiofrequency ablation, or gamma knife surgery. There are various procedures that are discussed, but the most commonly used one is anterior capsulotomy, where the lesion is produced in the anterior limb of the internal capsule. And the second most common technique is anterior cingulotomy. DBS, there are various targets that have been tried. I will be discussing about in the subsequent slides. So what is the rationale for DBS in OCD? So the most commonly discussed neurocircuitry model for OCD is the cortico-striato-thalamocortical model. These are circuits, brain circuits, which are arise in a particular region of the cerebral cortex, go to a particular part of the striatum, and then to a particular part of the thalamus, and then go back to the cortex. These are not single circuits. There are multiple circuits originating from different parts of the cortex. And each cortical regions generally connect to one particular part of the striatum, and then to a particular part of the thalamus, and then come back to the same region. So these are parallel circuits that originate in various regions of the cerebral cortex, especially the frontal cortexes. Although these are parallel, there is some connection between these independent circuits, especially in the striatal region. So why that is important, I'll be coming to that in the subsequent slides. So this is the latest CSTC model that has been discussed in OCD. This has been discussed in Nature Review Disease Primers. Dr. Janathan Reddy is the co-author for this paper. So it discusses there are six different circuits which seem to be impaired in OCD, and each have effect on different functioning, and many of these circuits might be implicated in the pathogenesis of OCD. So people have suggested that probably various treatments, including medications, surgical techniques, or non-invasive neuromodulation, work on different parts of this circuit. So, like for example, TMS and TDCS work on the cortical regions because they are able to stimulate or modulate only the superficial cortical regions, while surgical techniques target more deeper brain regions. So what is the advantage of targeting the deeper brain regions compared to the superficial brain regions? As I said earlier, in the striatum, all these parallel circuits originating from different regions of the cerebral cortex sort of talk to each other. There are interneurons that connect to each other, and these circuits are interconnected in this region. So if you target the striatal regions, you might be able to target multiple circuits instead of one circuit. So that seems to be the advantage of DBS compared to superficial brain stimulation. So this is a hypothesis, although not yet proven, based on which DBS has been proposed. So based on this hypothesis, these are the commonly used targets for DBS. So as I said, the internal capsule, this is the anterior limb of internal capsule, where a lesion used to be produced, where the white matter tracts connecting the frontal region to the cortex, so to the striatum passes through, and the DBS is generally provided in this region. So anterior limb of internal capsule is one area, and it's in the neighboring region called nucleus accumbens, bed nucleus of striatum amylase. All these things are neighboring regions which are involved in things like nucleus accumbens is involved in reward pathway, bed nucleus is involved in anxiety and fear related pathways. So DBS targeting these regions have been found to be helpful in OCD. So the issue with this particular target is that these four regions are very close to each other. So when you insert a DBS electrode, it may target any of these regions, and it's a bit difficult to sort of adjust which particular region you want to target. So yeah, so generally these four regions are considered to be similar in terms of location. The second most commonly used target is anteromedial subthalamic nucleus. I'll be coming to it later. Subthalamic nucleus is a target for Parkinson's also, but in Parkinson's, the posterior or motor part of subthalamic nucleus is targeted. But in OCD, the anteromedial or the emotional and associative or cognitive part of subthalamic nucleus is targeted. So I'll be briefly going through the DBS procedure, how a DBS procedure is generally done. And after that, I'll be discussing about the evidence for DBS in OCD. So generally before DBS, we generally do a pre-surgical workup where we need to confirm the diagnosis, review treatment history to establish treatment refractoriness. Then we do MRI of the brain to find exactly where you want the target to be placed, the electrode to be placed. Then we generally do a neuropsychological testing to see if there is any sort of dysfunction, cognitive deficits that can be seen before and after surgery. So neuropsychological testing is a must. And generally at NIMHANS, what we do is, apart from our assessment, we send patients to an independent committee consisting of a neurologist, an independent neurosurgeon, psychiatrist, and a neurologist who are not associated with NIMHANS. So these people also see the patient and suggest whether the person will be suitable for surgery. And there is a head of the panel, Dr. Kalyan Sundaram, who's a psychiatrist not attached to NIMHANS. He also, only when these people sort of accept for the procedure, we go ahead with psychosurgery. So yeah, so I'll be just showing how DBS is done for subthalamic nucleus because that is the target we generally use. This is the subthalamic nucleus, if you can see. Sorry, this is the subthalamic nucleus, this red nucleus. So the yellow one is the target for Parkinson's disease. The green one is the target for OCD. That is generally, yeah. And after the target has been decided in the MRI, we fix and frame to the patient's head. And this frame sort of helps us in guiding how to pass the electrodes. Because we know how it is inside the brain, we want to see from how to pass the electrode from the scalp. So we had to fix a frame. And after the frame, we do an MRI. And then we fuse the preoperative MRI, and an MRI with the frame. And then we see, if you can see, so basically this is the trajectory through which the electrode should pass. So we make sure that it doesn't pass through the ventricles or it doesn't pass through any vessels. So after that has been established, we go to the next procedure, which is the insertion of electrodes. As I said, these electrodes have multiple contacts, usually 4 or sometimes 8 contacts are also there. But for subthalamic nucleus, this is the commonly used electrode, where 4 contacts are seen. The surgery is usually done under local anesthesia. So the person is completely awake. For example, there is a video, if you can see in YouTube, where a person with essential tremor undergoes surgery while he is playing violin. So they want to see whether DBS improves the performance or so. So the patient is generally awake, and so you're able to monitor for any side effects or acute effects during surgery. And this is the stereotractic frame, and this helps through this frame, we insert the electrodes. And once the electrodes have been inserted, we do a recording from the electrodes to see whether we are in the target. I'll just show a small video where you can see when the target is reached. Yeah, you can see now the waves, high amplitude waves are seen, these spikes are seen. That is when we reach the subthalamic nucleus. So we are doubly sure that we reach the subthalamic nucleus. So apart from the preoperative imaging, we also do an intraoperative recording to confirm whether the electrodes are in the right position. And after that, we do an intraoperative stimulation to see whether there are any side effects or not. If there are any major side effects, we can change the position of the electrodes. And once that is done, there we do another step for confirming the electrodes. One is CM is sometimes used. We do that. And apart from that, we do immediately a CT in the theater. And then we fuse the intraoperative and postoperative image, in the sense that we fuse the CT with the MRI that was done earlier, because CT doesn't show the subthalamic nucleus clearly, but CT shows the electrodes. So when we fuse that together, we can see whether the electrode is exactly the subthalamic nucleus or not. This is the image where we confirm it is in the right position. And once that is done, then the next step where the battery can be inserted. This is just, there are softwares. This is a freely available software called eDBS, which we have used. This is a software which is used in one of our patients. Based on preoperative image and postoperative image, if you use it, and it will show some standard atlas. For example, this is the subthalamic nucleus. It will show us whether we are exactly the subthalamic nucleus, and especially, so for example, this yellow is the limbic part of subthalamic nucleus, and the blue one is the associative part of subthalamic nucleus. The target should be between these two. So if you see that the target is like we are in the right place, we're in the junction between these two regions of the subthalamic nucleus. So yeah, this also aids and helps us in confirming whether that we are in the right position. So next step is the insertion of the battery. This is the battery which is inserted generally in the beneath the in the subclavicle region, just generally in the chest. We usually do it on the right side. So generally there are two electrodes coming from each hemisphere, and both are connected to the same battery. There are two types of batteries that are used. One is non-rechargeable, where the battery provides continuous stimulation for 5 years, 2 to 5 years. When it is expires, we have to replace it. Generally, subthalamic nucleus batteries last longer, so usually 5 to 7 years. Yeah, but anterior limb, usually the battery gets over within 1.5 to 2 years. There are rechargeable batteries where the battery has to be periodically recharged, and that usually every 24 to 48 hours it has to be replaced, so recharged. The advantage is that it lasts for a longer period, so you need not change the battery later, but it's a bit expensive and it's a bit cumbersome. The disadvantage is that when the battery suddenly sort of gets over, there may be a sudden rebound in symptoms. Generally in mood symptoms, it has been seen. So that is a disadvantage with rechargeable batteries. We generally use non-rechargeable batteries. So the next step in the treatment is programming, where the programming is done with a handheld device. There are various things that can be manipulated. So this is how the electrical stimulus looks like. There is no continuous stimulation. The stimulation happens in pulses. So this is one pulse and this is the second pulse. So these brief pulses of electrical stimulation is generally given. And this, I'm sorry. So the duration of each pulse is called as pulse width, which is measured in milliseconds. For example, we use or microseconds. So for example, for our patients, we usually give a pulse width of 60 microseconds. And frequency is the number of pulses that are given per second. We usually give it at around 130 microseconds or 130 hertz. So apart from that, we can also manipulate the amplitude of stimulation, which is either measured in milliamps or voltages. So it sort of gives us to the radius of stimulation. So higher the amplitude, the larger area is stimulated. The fourth thing that can be sort of manipulated is the contact. As I said, there are 4 contacts. You can either keep one of the contacts on, another off. So for example, in this patient, we are keeping this contact, which we call as contact number 9 on. And this is the cathode and the battery is the anode. So anyway, the simulation is surrounding this particular contact. And we are giving the simulation at 4 milliamperes. So this is the radius for which it stimulates. So this stimulation is generally done over the next few months following surgery. This sort of adjustment of stimulation parameters. So this is based on the tolerability and acute effects, whether you see any important acute effects. So generally it has been seen that for OCD and others and depression also, the contacts or the stimulation parameters that leads to acute elation in mood are some sort of laughter sort of responses are likely to be helpful because we are likely to be in the limbic region of the target. So yeah, so based on that we do it, and generally the stimulation sort of parameter adjustment lasts for between 6 to 12 months. So with this background, I'll be discussing about the efficacy of DBS in OCD. Yeah, as I said, first, there are 2 main targets. One is the ventral capsule, ventral striatum target, which includes all the internal capsule and neighboring brain region. This is a commonly targeted brain region. And there are many studies conducted, but I'll be just showing one study as an example, where a large study, it was recently published, around 70 patient clinical cohort of 70 patients were tested. And there was a mean Y-box reduction of 13.5, which is a great response generally for OCD, because especially considering that these patients are treatment resistant. So this study showed that around 50% of patients respond, and then 17% of patients have partial response. So yeah, so this target has been consistently found to be effective. As I said, the second target, which we also use, is anteromedial subthalamic nucleus. As the subthalamic nucleus is also part of the corticostriato-thalamocortical pathway. But yeah, it's a part of the indirect. There are generally three pathways in it. One is the direct, another is indirect and hyperdirect. Direct is sort of excitatory, indirect and hyperdirect are inhibitory. Subthalamic nucleus is a part of the inhibitory pathways of the CSTC circuits. So that is generally targeted. So as I said, there are three regions in the subthalamic nucleus. This is the motor region, this is the associative or cognitive region, and this is the limbic or emotional region. For Parkinson's, we do it posteriorly on the dorsal mortal region, but in OCD, we target the anteromedial junction between the associative and limbic cortices. So this is a very nice study conducted by Luc Meillet et al. From France, where, as I said earlier, they sort of kept the DBS stimulation on for 3 months. They gave a washout period for 1 month and off for 3 months. So subjects were divided into two groups. For some patients, it was kept on first and then off later. For the other people, it was kept off first and on later. So patients as well as the raters were blinded. So as you can see, whenever the stimulation was on, the Y-box score decreases. And when it is off, the Y-box score increases for both groups. And similarly, parallel improvement in global assessment of functioning or functioning was also noticed. So this study is one of the most well-conducted studies for DBS in OCD, which proved through a randomized double-blind controlled trial showing that DBS is helpful in OCD. And because of that reason, that's some of the guidelines also suggested subthalamic nucleus as the treatment of target of choice for OCD, mainly because the quality of study is quite good in terms of RCT. So there was another interesting study which sort of compared the two targets. So this is conducted by a group in UK, Tyagi et al. So what they did was they inserted, for the same patient, they inserted electrodes both into the ventral capsule as well as the subthalamic nucleus. So they kept, for 3 months, they kept one target on, for 3 months, they kept the other target on, for 3 months, they kept both on, and for 3 months, they kept both off. So patients were blinded, raters were blinded. And what they found was both the stimulation of both targets were equally effective. But interestingly, mood symptoms improved better with the ventral striatum, but the cognitive the cognitive deficits improved better in the subthalamic nucleus. So they say that both targets might be equally effective. So there was one more study by Luc Meillet et al. Which showed similar findings. So based on that, a lot of people started thinking, if all targets are equally effective, whether the target is important or whether the tract that runs through these targets are important, rather these axons which run through these targets are important. So this is a very nice study done by Ningfeng Li et al. It was published in Nature Communication. So where they tried to find out whether different sort of targets, DBS for different targets, whether they target the same white matter tracts. So they, I'll not go into the details, but finally what they found is the red tracts are the ones that are found to be helpful in treatment of OCD, and the blue ones have been negatively associated with improvement. What they found is both, irrespective of the target, all the targets target the same tract that passes from the medial frontal cortex to the subthalamic nucleus. So based on this, they suggested a hypothesis which has been confirmed in a few other studies also, showing that this particular tract is probably the tract that we have to target in OCD. And this is just to show, in one of our patients, we tried to superimpose this tract with one of our patient's electrode, and we found that fortunately the electrode was very close to that to this track, the highly effective track. Hopefully, this patient should improve. The surgery was just done about 2 weeks ago, so we are waiting for the response. So overall, what is the response rate? This is a meta-analysis which says that around 60% of patients respond to DBS. This is for acute response. So with an overall reduction of 45%, which is very good considering that this is a treatment refractory population. And some studies have tried to find the predictors. Older age of onset and sexual religious option have been found to be predictors of response, but in this study, but it's not been very consistent. So there are no clear-cut predictors of response. So what about the long-term outcomes? So there are outcomes studies have been done up to 9 years of follow-up, and they found that recent studies have found that efficacy actually improves over time. So for example, in a recent study, they found that 75% of patients had improvement, and there were no major long-term side effects also. And it has been found to be cost-effective as compared to treatment as usual. And another important thing is that people who don't respond to CBT before DBS may respond to CBT after DBS. So it has been found that CBT and DBS and CBT augment each other. So generally after DBS, after some time, we can attempt another course of CBT. And as I said, generally it has been seen that the battery lasts longer for subthalamic nucleus, so 5 to 6 years compared to 1.5 to 2 years for the other target. So what are the adverse effects? So not everything is rosy. Since it's an invasive procedure, there are some rare side effects. It can be divided into 3 groups. One is complications of the surgical intervention itself, because we are inserting an electrode. There can be rarely hemorrhage, post-operative infection, and sometimes seizures. These are relatively rare nowadays as because of preoperative precautions, antibiotics, and other things. Second group of side effect is device related, where the lead might break if the lead or electrode might break, which is also a very rare side effect. But the most notorious one is depletion of battery. When the battery sort of gets over, there is a sudden rebound in anxiety and depression. So generally, we will be able to find out the person has a device through which the person will be able to find out when the battery is getting over, and the person can go for replacement of the battery before it gets over. The third is the most common side effect, which is the adverse effect of stimulation. It can lead to various different side effects depending on which brain region we are targeting. It could be physical symptoms. It could have some psychological symptoms also, especially mania and hypomania has been seen. So the advantage of these is that these side effects can be these are reversible side effects, because once you change the lead, which the contact which you're stimulating, or when you're adjusting the stimulation parameter, these side effects can be reversed. So yeah. So overall, the side effects are comparatively less with DBS. So based on all this evidence, as I said, there has been a recent guideline for DBS for OCD, and where they say that there is level 1 evidence for DBS over subthalamic nucleus, level 2 evidence for DBS over nucleus accumbens and BNST. And FDA and CS certification do exist for DBS for OCD also. So to summarize, DBS has a role in carefully selected patients with treatment refractory OCD. The capsule, striatum, and subthalamic nucleus are the commonly used targets. Long-term, people have found that around 60 to 75% of patients improve with treatment. But it should be remembered that it is not a standalone treatment. It is just one part of the treatment, in the sense that even after surgery, in the sense that many patients do ask this, they ask whether we can stop the medicines, can you do surgery and treat OCD once for all, which unfortunately doesn't happen. We might have to continue both medicines, and if required CBT also, even following surgery. So this sort of augments treatment in refractory people. There are no clear predictors of response. This is a study which, this is my fellowship study, where we are aiming to identify the biomarkers that predict response to DBS in OCD. This protocol was recently published in BMJ Open. So basically, we are trying to find out the biomarkers based on MRI, electrophysiological activity in the form of EEG and recording from subthalamic nucleus, and cognitive performance, whether these things predict response to DBS and OCD. So this would help us identify patients who are likely to improve with OCD, and so that we can start DBS only in this select population. So this is the aim of the study, 5-year study, where this is the study design, where for 24 refractory subjects, we'll be doing DBS and following them up with 1 year and doing all the necessary biomarkers to see who responds to treatment. We have already done surgery for 2 people now. All subjects in the study would receive open label DVS with 1 year follow-up, and this would be funded through the research project. So the DBS is free, and even 1 year follow-up will be funded through the project. Yeah, and we are collaborating with Luc Mallet from France, who did that NEJM study on subthalamic nucleus. And the surgery is done by Dr. Dwaraknath Srinivas, who has extensive experience for subthalamic nucleus DBS. Okay, thank you. This brings to the end of our presentation.
Thank you so much, sir, for a lucid presentations. Over to chairpersons.
I think you can start.
Thank you, Dr. Shyam Sundar. That was a very nice presentation, and there are lots of questions which are coming into the chat box. So I think we'll take them one by one. Just one minute. All right, so should I start with the questions? Would you be willing to take a few questions?
Sure, sir. Sure.
Yeah. So first of all, very nice presentation. I really enjoyed it. I've read a bit about deep brain stimulation, and what Dr. Shyam Sundar just talked about is a lot about the technical aspects. As he's already mentioned, DBS is like functional neurosurgery. It's like a successor to the old, permanent procedures. Deep brain stimulation ostensibly is reversible. But there are various ethical aspects which are involved. If we see like the Mental Health Care Act, for example, says that psychosurgery cannot be used, for instance, and on the other hand, for example, the IPS guidelines do suggest that deep brain stimulation has a role to play. So there are various aspects of this area, which it's a very vast area, even though the number of centers that do this procedure in India is probably not very high. So with these opening comments, what I'll do is I'll take these questions one by one. So the first question is by Dr. Ranjan, who says that what are the advantages of directional DBS electrode over quadripolar electrode? And there's another question by him. Ventromedial subthalamic nucleus stimulation can cause mood changes, incidence of hypomanic switch in clinical practice. So can you take these 2 questions, please?
Yeah, so directional electrodes, DBS electrodes, so if you see the normal electrodes, it stimulates all through the circumference of the electrode. So it's a 360-degree stimulation. Directional electrode has the advantages in that it can direct the stimulation to one side alone. So for 120 degrees. But directional electrodes have not been studied in OCD or in psychiatric disorders yet. So we are not sure whether we are there yet. Like, for example, if we are able to find that the tracts, like, for example, what I showed, if it is in a particular brain region, and if you are able to show that stimulating that particular tract is being helpful, maybe it might be useful. It is still being studied in Parkinson's disease, and in psychiatric disorders, it's not being studied yet. Coming to the next second question, it can cause hypomanic switch. Yeah, even DBS for Parkinson's disease, it's a common side effect. And also not only for, we are actually conducting a meta-analysis of this particular side effect now, comparing the risk of mania in different targets of DBS. So basically, this does happen across. What we have seen is generally it happens with subthalamic nucleus as well as ventral capsule, ventral striatum target, and it's a reversible side effect. It's usually hypomania, and once you adjust the parameters, stimulation parameters, it improves. So it's generally not a major side effect.
Sam, you can also comment on. I think Dr. Singh was mentioning that regarding ethical aspect, mental health act does not really permit psychosurgery to be used as a treatment in OCD. But my understanding is that you have to go through Central Mental Health Authority.
Yes,
it's not that it does not permit, but you have to get the clearance. Whereas what Shyam Sundar is doing under DBT Welcome is a clinical trial mode. So there are different kinds of ethical approvals. But then if in a clinical practice, if one wants to practice neurosurgical interventions of any type for psychiatric patients, I think we have to go through State Mental Health Review Board. Am I right, Shyam?
Yes, we have to go through the State Mental Health Review Board.
So your procedures right now are in a more of a research setting, or is it like
Yes.
I
Is
think
it
that's
clinical
an
trial?
important distinction to make because and what are the kind of, if I might ask a question, what are the kind of patient population that you have? I mean, so for instance, what are the numbers that we are looking at when we talk about these evidences?
Okay, so for OCD, I think it will be till now around 200 to 300 patients worldwide have been given DBS, have been reported in the literature. So yeah, that's for OCD.
Yeah, because I had once reviewed this area and I found that the very nature of the treatment kind of reduces the numbers a lot, in the sense that it's a kind of a self, it kind of, the nature of the treatment means that your patient numbers will always be on the lower side. So the robustness of the evidence will consequently be also on the lower side. And so it's like a self-fulfilling prophecy in the sense that it's like a vicious cycle that keeps on going on. Unlike, say, Parkinsonism, where deep brain stimulation has a much more robust and much more accepted sort of place in the treatment armamentarium.
Yeah.
Anyway.
Yes. Actually, the issue is it can't be done in many centers. So
yes.
Yeah, and the acceptance rate also like slowly because so DBS actually in Parkinson's disease, it's a much older population and it's been more commonly used over there. But probably in the younger population, people have some apprehension. So the more it is used, probably I think the acceptance also might increase.
That's saying, I think your concern is right. There is also one additional issues. People somehow cannot come to terms with the fact that psychological problems can be cured by surgical procedures because your routine MRI doesn't show anything in the brain that can be operated upon, right? So it's very hard to convince patients that you need to undergo surgery strangely, by hypothesis. All our surgical interventions are based on hypothesis, okay? They're based on certain hypothesis about certain circuitry malfunctioning, and that we are saying you're putting an electrode to, make those oscillations okay. So it sounds a little fancy for them somehow, and they may not always be convinced about. Whereas Parkinson's disease is a neurological disorder. You are shaking, you are trembling. It's much easier to convince them. I guess this is one important reason. In fact, we see quite a few patients who are eligible for surgery, but then if you talk to 10, how many agree, Sham? Not more than 2.
Yes, sir. Yes, 1 in 5 people.
Yeah. So it's a challenge. I agree.
I think we've also referred a few patients from our center. So it's a pretty uncommon, modality as of now. So Dr. Pradhan has asked, what's the efficacy of DBS in OCD in India? So is there any meaningful difference between our results and the results that are reported elsewhere?
There are no systematic studies in India. So there are a few case reports which have shown similar response rates actually, but these are case reports, 2 patients, 4 patients. So there are no systematic studies.
I seem to remember that there are some case series of 2 or 3 patients and a couple of case reports in there with regards to functional neurosurgery in OCD. Anyway, all right. Has DBS found its place in European guidelines? Deepak Moyal, old friend of mine.
European guidelines.
Yes.
Actually, the guideline which I suggest, like I showed for functional neurosurgery, it's an international guideline, and it has many people from Europe also. So where it has been discussed, like for OCD. Yeah.
Okay. Dr. Naseem Akhtar, I'll just come to you in a moment. All right. There's one more question. What is the standard guideline for treatment duration to conclude response to DBT? So when do you know that it's working? And for example, if it is not working, then what do you do?
Yeah. So 6 to 12 months. Generally, we wait for 6 to 12 months. That is both for ablative surgery as well as DBS. And if it is not working, some patients, there are some some reports where people have tried a different target also, or people who have undergone ablative surgery have been tried on DBS, and people who have not responded to DBS have been tried on ablative surgery. So all these things have been tried also. And yeah, so these are because this is a refractory population, so we have to go experimental in this population. There's no other option. So,
And you'll have to turn off if they were convinced that it does not work, but you don't remove electrodes, they remain in your brain forever, Sham.
Generally, it's not removed.
Yeah, generally they're not removed. I mean, there's a question that people ask, can you remove them? So
generally, why to go for another surgery when it is, it's not harming you.
So the electrodes are basically inside you for the rest of your life.
Yes. If you want, you can remove it. Like if it's causing
are
some
these
complications.
MRI compatible?
There are two types of some electrodes are MRI compatible. So there is a recent electrode which is early electrodes used to be 1.5 Tesla compatible, but the recent electrodes are even 3 Tesla MRI compatible.
All right. Yeah.
So, but that's important because the patient has to know which electrode the person is having, so that if at all they want to go for MRI, that has to be mentioned.
Yeah, because as they grow older, the chances of requiring an MRI at some point would increase.
Yes.
All right. There's another question. Do you have a protocol to complement TMS post DBS? Can you use TMS in people who have an electrode?
We can't use it because magnetic stimulation, and already there's a brain implant. It might be dangerous, displacement of the electrodes and sort of thing. So we should not use TMS. TDCS might be safer in that regard.
That would be a kind of a contraindication.
The TMS,
What about TDCS? Would TDCS be a treatment that could be used for the?
There is no I've not seen any reports that have used it, but actually it should not cause any major issues because it's a superficial. It's it's an electrical stimulation, so it should not have any major issues.
Dr. Naseem, can you? Oh, sorry. I'm sorry, Dr. Naseem. Would you? Can you just type down? Could you write down your question in the chat box? I think that would be easier for everyone to.
No, I don't know where to type and how to type.
All right, really. All right. Yeah, but please ask your question. I think.
I have some comment. First thing, Dr. Shyamchandra has presented this difficult and complicated topic in a very easy language, understandable language. I have just two comments now. One comment is that if OCD starts at younger age and keep on going and progressing and becomes resistant, this is a very important prognostic factor. The prognosis will be very bad as compared to those patients who develop OCD at adult's age or a bit middle age patient. Number one. Number two, I have just read one article from Frontiers in Psychiatry. They reported that the use of deep brain stimulation is decreasing worldwide. Third comment, the studies that have did this deep brain stimulation, they have very limited number of patients. Sometimes 4 patients, sometimes 3 patients, sometimes 7 patients, not patients like in thousands, So that minimize that, I mean that does not support the very frequent use of deep brain stimulation. And last but not the least, if the pay, for example, in America, there are different type of payments, done by different companies. If the patient get something like free deep brain stimulation, the prognosis is reported to be good. And thank you very much, sir.
Thank you, sir. So,
Can I ask these questions to you one by one? So does age at onset make any difference? Are there any specific symptoms which respond better or worse, or do not respond as well to DBS?
there are no consistent predictors of response, but there is some evidence that, yeah, like what Sir said, it's like people with later age of onset respond better. There is some evidence to suggest that. And regarding the type of symptoms, people with there is some evidence to suggest that sexual religious sort of obsessions are more likely to respond, but that is also it's not very consistently found. Like as Sir had said, that like the studies are done in very small numbers, so it's difficult to identify particular predictors of response.
Yeah, so we've already discussed the low number of patients. I think that is expected with the nature of the treatment and the fact
Yes,
that
I have a small comment on that, sir, but because I think especially in two centers, Sweden and US, they have accumulated a large experience. So maybe around 100 in each, 70 to 100 in each center. And they have shown some positive response. So yeah, but apart from that, all other centers have shown in either single or double digits.
yeah.
We are unlikely to get the kind of evidence that we get from pharmacotherapy and psychotherapy trials for DBS. So therefore, it has to be reserved in a select population when other treatment options have failed and when OCD is very, very severe and disabling. So it's not going to be a kind of a treatment that people walk in and ask for a surgery. So therefore, we should be careful in selecting patients and also not to overdo and then make it unpopular as well, as it has happened in the past. So I think those are the real challenges in a routine clinical practice. And
Yes,
FDA also has given humanitarian device approval. It is not a regular scientific approval that it gives to clinical trials. So it's a very challenging area. But I think the protocol that Shyam Sundar is right now, the protocol that he has implemented has a reasonably good number, 24. You might ask why not 58 demands? It's not easy to. We are really struggling to get these patients with COVID and all that. So, of course, that is a challenge.
I would agree that 24 is a very creditable number for any center.
And then we obviously require all of you to refer patients for suitable ones.
Yes.
There was a point made about payment and insurance and DBS. Would you like to comment about that?
Yes, possible. It's a very expensive treatment. So there is some sort of maintenance cost also for the treatment. So
I mean, your patients are paid for by a project. Is that right?
Yeah, in my project, the whole treatment is paid by the project, so it is free of cost for patients.
So you told it was cost effective. So how do we calculate that?
So basically, what they did is they took a comparison group of people with refractory OCD who are not done DBS, and they found that people who did DBS, their functioning improved. So basically, they looked into for the amount of cost that was provided in terms of surgery, the improvement in functioning sort of compensated for it compared to the other group.
Okay, so what would be the estimated cost in a public sector and a private sector?
In a private sector, it costs around 10 to 12 lakhs. In public sector and MNs, we generally charge around 5 to 6 lakhs for the procedure.
Okay.
I mean, is the main cost of the electrodes or is it the procedure?
It's the batteries. The battery is the most expensive part of it. It costs around 4 lakhs.
Sir.
Yes, sir.
How convinced are you about this in OCD, and where would you put it in if Janardhan sir has to put it in the whole algorithm of OCD, where would you put it? And would you recommend with the whole lengthy procedure, the costs involved, if it's not given free of cost?
Amrut, both me and Shyam Sundar were the lead people in that guidelines. We have obviously recommended surgery for it has to be not just chronic OCD, it has to be severe, chronic, disabling refractory OCD. None of these terms are replaceable. It's not enough just to have chronic OCD. There are people who have come and asked us for surgery when their Y box is 17, 18 or 20 because they just think that you put an electrode and I can forever live happily. Now, no, those are not the patients. There has to be, that's why I think the Y box score and also global assessment of functioning score is used as a cutoff score for recruitment. You know, it should be really an incapacitating OCD for, you know, for someone to opt for surgery. Yes, I would, if you ask me, it is an option. It is an option which has to be used judiciously because we are running a OCD clinic. We know, every time we sit in a OCD clinic, it's not necessarily always a pleasant experience because you run through so many trials and CBT and everything else, sometimes multiple admissions. We still are, helpless. So it might offer some hope to some people, but we have to be careful in what we tell patients when we offer them surgery. Don't oversell it because it doesn't work that way. But also don't make it sound as if it is a last treatment in the world and nothing happens. We know there is no last treatment. Many of these patients can improve over a period of time. Many things can happen in the natural course of illness, which is not the last treatment. In fact, what we tell is from a slim evidence, there is some hope that other regular treatment might work better. Maybe because you induce some neuroplastic changes in circuits, CBT might work better. We don't know. So we should be very careful that we don't sell it as a last strategy because sometimes if you sell it as a last strategy and nothing else after that, it should be, there is a chance of increased suicide risk, and those issues also have been discussed. So I think there is a place, but yes, I mean, that's the way it is.
Thank you, sir. Thank you.
I think, sir, there are patients who are extremely severe, like what sir was saying. For example, we had a patient who used to wash, like if she goes to the bathroom, she comes out after 72 hours. So for her, we had to do a capsulotomy, and currently she comes out of the bottom of 3 to 4 hours. So it's a dramatic change in quality of life for the patient. So there are a subset of patients who are extremely severe for whom it has been helpful. Yeah. So, but not for every patient. So some, like sir said, some of the patients come and say whether it can be a replacement for medicines or CBT. No, that's not the way. Only for people for whom other treatments don't respond, it might be helpful.
And it is also very important that we don't sell it as a treatment which may never work, which is not true. The evidence from whatever we have, it seems to suggest it is reasonably effective. And we need to balance that, because if we start saying people that it may not work, but we're going to try it, that's really not a great communication. So it's a fine balance.
Thank you, sir.
Okay. I think there are no more questions in the chat box. There was one regarding the treatment duration, I think. When to conclude the response rate.
That time,
I think we responded to that.
6 to 12 months. Generally, within 12 months, if there is no response, we generally consider.
Okay.
Okay, so are there any other questions?
If there are any questions, you can post in the chat box. I think the topic was very well summarized, and such a complex topic was presented in a very, very lucid way. So I was able to understand what sir was trying to say, and definitely I think we should try and get some patients who are really in need, refer them to Dr. Shyam Sundar, because some of the OCD treatment, some of the OCD patients are very severe and everything fails them. So I think, as sir was saying, those who are very resistant, chronic, difficult to treat, there we can consider it as an option, as an add-on option, you can say.
Yes. Thank you, sir. Thanks a lot.
Yeah. Tofan sir, over to you. And I think you have to say the vote of thanks also, because Amrit's internet was not working properly.
Okay, thank you, Alim. First of all, I'm sorry that I was in a dark road when the program started. I checked, logged in out of my mobile phone, and they did not want to bore you with speaking from darkness. And it was my responsibility to introduce the chairpersons, Dr. Shumon Singh and my dear friend, Dr. Janardhan Reddy. I was not there, but I take this opportunity to greet you, as well as Dr. Shamsundar, who has made a very elaborate presentation. I was very much interested to listen to this. I believe, my opinion is that given the fact that the patient is refractory, severe, and debilitating OCD, then it can be option. The bottlenecks are the cost, because all the patients are not going to be treated to a project of Dr. Reddy or someone else. The cost, and second thing, how much really we convey to the patient by we take the informed consent. At the level of the understanding of the persons, telling nucleus ambience does not mean anything to him. And how much we promise, how realistic we are, these are the bottlenecks. But given that the person is not going to do anything, is disabled, refractory to all other available modes of treatment, psychotherapeutic, behavioral, as well as medicine, and is severe, this is absent because one has to gauge the pain of this obsessive person. When he does not improve and is going through the symptoms, this is absent, which has to be rationally explored. There are many medical problems can be there. So this has to be very slow, but this has a promise, and all promises for a better tomorrow have to be explored. Thank you very much. Thank you, Dr. Suman Singh. Sorry I could not be there. And Dr. Reddy.
Thank you, sir.
I was behind darkness. I did not want to sound like a ghost speaking. So now I have reached home and I am logging in from my laptop. And it was a nice session. We had a very good attendance. And on behalf of the Indian Psychiatric Society Odisha State Branch and Trust Imaging Team, I convey sincere thanks to our chairpersons, our speaker, Dr. Shamsundar, and all the persons who have logged in to attend and continue to encourage us. Thank you. And at the end, last but not the least, my gratitude to Current for sponsoring this series. Thanks, everybody.
Thank you. Thank you, everyone.
Thank you.
Thanks a lot.
Thank you so much.
So, Dr. Reddy, at a personal level, we can refer cases where we feel.
Yes, sir. Please do refer.
And hoping to be in the project.
Yes, sir. You refer. But there is one thing that I want all of you to, if there is a good therapist, exhaust it. What really happens is many patients come to us with multiple pharmacological trials, but they have not have undergone CBT. But what we do is we offer them CBT if they are not undergone CBT. I mean, that will take a couple of months, and then even then, if they don't respond, then we suggest them surgery. But if you are convinced that your patients have undergone a CBT with proper ERP and they're not benefited, you say so, and then we will call you back. I think it will be a discussion when you send somebody, because when somebody wants to undergo surgery, I think Sham and his team and all of us are part of the team. We talk to family for a long time to convince or maybe to find out that they're suitable. So we don't simply put a scalpel.
Yes, I understand that. No, not like that, because one has to be transparent in communicating to the patient.
It's very, very important. Yes,
and potentiating him to take his decision.
Exactly.
Nothing imposed.
Please do refer patients to.
But I have got two patients who are real fixed criteria, and about therapeutic, behavioral and psychotherapeutic approaches. They have underwent treatment as available.
Okay, sir.
As available, this is within bracket.
Please refer them, sir. We will see if
so you can subject them to CBT and ERP over there. That I will also explain.
Yeah.
Yes.
If they are not undergone a proper therapy, we will definitely submit them once again. But when we take the history, if we are convinced that they have undergone good therapy, there is no need to repeat it again. But then in most situations, we don't find people who have received high quality CBT. So that actually
that is the story all over India. From my young days, I have been supportive of psychotherapeutic and behavioral therapeutic approaches, but the facility is very low.
Yes, sir. I agree.
With all regards, we have been taught by clinical psychologists that enduring our postgraduate days, maybe they could have been much better. So in small places that is there, the one person practices whatever he does, 2 testings, 4 testings. one psychotherapeutic session, हो गया काम. लड़की है तो उसके घर पे भी बच्चे हैं. And these are the limitations.
Yes, sir. Yes, sir. We are aware of that. Yes.
And to the best of my knowledge, now very rarely in the states where psychiatrists are less, psychiatrists practice therapy. But in major cities, psychiatrists will practice behavior therapy and psychotherapy. So these are the limitations. Okay, technically that might be exhausted, but I don't feel maybe they have to be again subjected to that.
Okay, sir. Thank you.
Okay, thanks for the promise. I believe in promises. Prepared to take risks.
Thank you, Dr. Singh, Dr.
Thank
Ali.
you, sir. Thank you. Good night and have a great evening.
Thank you,
And,
sir. Night,
Thank
I'd
you.
just like to say it was wonderful to be in a session where it was a lovely talk. I think I really enjoyed it. Thank you very much.
Another thing, can I ask Dr. Sumohan, because although I have concluded, suppose a person develops epilepsy with the electrode chain, what will happen?
Epilepsy is a very rare side effect, actually.
Not side effect, develops. Anybody can have epilepsy due to some reason or other, not necessarily related to the surgery and electrodes.
It should be okay, so that should not be a major issue, because DBS is also given for epilepsy also nowadays. So it should not be an issue. It won't, unless the person hurts the battery or something. Yeah, that otherwise it doesn't usually matter.
So thank you. Good night.
Thank you. Thanks a lot for the opportunity. Thank you.
Thank you, Alim.
Good night. Good night.
Someone of you or Amrit must have proxied for me.
Yes, we did so. I did.
Okay, thank you so much.
We can close the meeting now, Chintan.
Yes, you close and can you, Amrit, Alim announce about the Eastern Semi?
Yeah, next week, sorry,
Next week is Saturday.
Saturday on 2nd of April, we are having an international speaker. He's a very renowned person, Dr. Rakesh Jain. He will be speaking on the neurobiology of burnout and how we can manage it, we can take care of it. So he is a very interesting speaker to listen to. I invite you all, 8 p.m. 2nd April. Please do log in again. We'll post the links and flyers in the same channel we have been posting. So thank you so much. Close the meeting now. Chintan or Sanket, who was there?
I think Chintan is the one. Huh?